Who are we? We are not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learnt what so many of us have forgotten. The value of every single day. The preciousness of every breath, of every heartbeat. We make tears, tears of thanks for the release from pain. And then there's hope. The hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Alison, Seb, Topeka, and Zunaid. And that is why we are not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life.
Good evening, everybody. Hello. My name is Anthony Smith. I'm president of SASHA, and a warm welcome on a cold night in Cape Town to local and international guests to this sixth in the SASHA webinar series hosted in association with WAS and paving the way to the 25th Congress of WAS. By now, unfortunately for you, the abstracts are closed, submissions, but now is the time to register. And I want to take a little bit of time just to highlight a few of the satellites that are going to happen around the Congress, because there really is something for everybody. And I want to tell you very briefly about 3 of those satellites. So the first, the ISSM Sexual Medicine Workshop, is going to be a very, very comprehensive sexual health and medicine workshop on an approach to clinical sexual medicine, and anybody, clinicians or otherwise, who have an interest, who would like to be exposed and do a crash course in this, would be invited and would really gain from luminaries in the field from around the world presenting this. It really is going to be excellent. There's also going to be a SAR, which, for those of you who don't know, is a sexual reassessment and restructuring training. And this was a training, a revolutionary program originating from the Institute for Advanced Study of Human Sexuality in San Francisco, and was designed to help sexologists to broaden and be aware of the diversity in sexual expression and behavior, and is really a remarkable experience for those who want to seriously engage with sexual health problems in their clinical practice. So look out for more information on that. There's also a sexual justice indaba. This will be a participative justice indaba. It will be a dialogue and conversation on the subject of sexual justice, and a chance for everybody who has a stake in this to speak with each other, connect, and create something out of their conversation, a white paper which they can then present at the Congress. This, amongst many other things which are being prepared for the Congress, and I encourage you to register and keep your eyes open for what's going to still be presented. More information will come through as time goes by and as we get closer to the Congress. Tonight, this is an exciting event that we have planned for you. I would like firstly, to thank CIPLA for sponsoring and making this event possible. I also want to just attend to the usual housekeeping issues. You know, for those of you who've been with us before, about the questions. We like dialogue. We like you to be participating. Please ask questions. Tell us who you are in the chat. And please just engage with us. Please also know that there will be CPD points available for those who are members of SASHA. Certificates will be mailed to you shortly after the event. Let me please, at this stage, with great pleasure, introduce the 2 moderators. Firstly, Dr. Corlia Brandt. Corlia is a pelvic floor physiotherapist and currently a senior lecturer at the University of the Witwatersrand, where she integrates research, clinical practice, and teaching. You will see her full bio in the chat. Welcome, Corlia. I also, with great pleasure, welcome back Dr. Uwemedimo Esiet. Uwem is a public health physician with over 30 years of experience in the development sector, with a focus on advancing sexual and reproductive health and rights for all. He is also the honorary president of the 25th Congress of the World Association of Sexual Health, and you can also see his full bio in the chat. Welcome, Uwem.
Thank you, Anthony, and welcome everyone to this very, very important webinar. As you know, we are getting the issue of sexual health in the public health system. And my take is that we are trying to look at the issues around justice and equity. And but let me start by echoing something that Anthony said. There is going to be another innovation at this Congress. There is going to be a youth pre-Congress. And this is the very first time that WAS will be having a youth pre-Congress at its World Congress. And it's going to be open to all the young people across the world. It's going to be youth-led, and it's going to be phenomenal. Well, let me now move on to the preliminaries for this webinar. According to the World Health Organization, more than 1 million sexually transmitted infections are acquired every day worldwide. At least 74 million women living in low and middle income countries have unintended pregnancies annually. This leads to 25 million unsafe abortions, and 47,000 maternal deaths every year. At least 10 million unintended pregnancies occur each year among adolescent girls aged 15 to 19 years in the developing world. Of the estimated 5.6 million abortions that occur each year among adolescent girls aged 15 to 19 years, 3.9 million are unsafe, contributing to maternal mortality, morbidity, and lasting health problems. 1 year into the pandemic, that is the COVID-19 pandemic, UNFPA estimates that 12 million women have seen contraceptive interruptions, leading to 1.4 million unintended pregnancies. Estimates published by WHO indicate that globally about 1 in 3 of women worldwide have been subjected to either physical and or sexual intimate partner violence or non-partner sexual violence in their lifetime. Big question. Can anyone imagine that all over the world, when people want to find consensual sexual expression, they are faced with grave and sometimes deadly outcomes, such as sexually transmitted infections, including HIV/AIDS, and unwanted pregnancy. And it is very worrisome that amongst young people, because of lack of access to comprehensive sexuality education, we have so many millions of them having pregnancies that they do not want, that they did not intend. So for me, and looking at the whole phenomenon of development around the world, from the new norm in 2020, we moved MDGs now to SDGs. And what is the slogan? Leave no one behind, which is also the slogan of the WAS Congress. This suggests that already we have left many people behind. Does that talk to you? Is that social justice? Is that sexual justice? Or is this injustice or lack of justice? So what is sexual justice from my own perspective? Sexual justice affirms that all human beings are sexual beings with autonomy and agency, and that there is no stigma, discrimination, coercion, and repression tied or experienced when people try to express their sexuality. Of course, public health is not looking at the health of one person. We are looking at communities or populations and a combination of science and social approaches. And then this results in protection, prevention of disease, and promotion of well-being. We are to have Dr. Sarah Onyango as our lead presenter today. Unfortunately, about 8 days ago, Dr. Sarah Onyango suffered a fall, and that meant she had to have surgery. So she's still recovering, and we hope that she'll be able to join us and make some inputs. But who is Sarah Onyango? Sarah is a medical doctor and holds a Master of Public Health from the University of Nairobi, Kenya, and a Master of Arts in Health Research from Lancaster University in the UK. She is currently the Senior Technical Advisor of Self-Care at Population Services International and contributes to accelerating Population Services International Self-Care Agenda. She has a wealth of experience and expertise in sexual and reproductive health and rights. And I'm going to be speaking to her presentation very, very shortly. I think we can have her slides on because she tried to interrogate this topic from a service delivery point of view in the public health setting. So the next slide. Next slide, please. Yes, the public setting, health setting, has the overall goal of ensuring that a country have access to the full range of essential health services to ensure the health and well-being of people. Bottom line, it means that everybody is meant to be catered for. However, we know that some groups are often marginalized, and these are especially the most vulnerable members of society, and this could include adolescents and young people, women and girls in some situations, people living in humanitarian situations, the poor, just to mention a few. The public health system mandate defines minimum package of essential services. And this is often a matter of resources available to the health ministries that will ensure the provision of these essential services. Sometimes also the provision of comprehensive health services in the public health system is due to the availability of motivated and well-trained health personnel, which we know in the less developed and middle-income countries that they are always overburdened. The public health system is challenged in its effort to deliver quality and comprehensive health services. So, what works well? Services in the public health system are generally more affordable and therefore accessible to a larger group of people, including the vulnerable and marginalized. In the public health systems, in most countries, there are a lot of vertical programs, and the programs are never integrated. The public health system has strong linkages with primary health care and community health service delivery. Wow, what are the gaps? I'm sure all of us will know what the gaps are. In most low and middle income countries, they are stretched and overwhelmed. And the focus is on every other thing except sexual health services. Sexual health is either not prioritized or totally not included in the essential health packages of most countries. In fact, in one of the countries in West Africa, there has been a long debate as to should girls, adolescent girls, have access to free menstrual hygiene materials, menstrual pads. That after all, condoms are male condoms are literally available for free everywhere. And that has been a strong debate. Sexual health issues are stigmatized and marginalized. In most cases, staff are not designated to provide these services. In many instances, no space is allocated for the provision of sexual health services. So issues of privacy, confidentiality, and the rest are compromised. Now, how do clinicians or other stakeholders try to address these gaps? Digital health, one of the advantages or one of the things that COVID threw up is that we have found ways to use more of digital health services, including telemedicine and other innovative opportunities to reach clients, especially with sexual health needs. Self-care is also an area of healthcare that is advancing. And self-care empowers the individual to provide services to one's self. A range of sexual health services, including screening for STI, can be provided through self-care. And as you know, WHO has already come up with a guidance on self-care. It is important for sexual health activists to build networks and partnerships with key stakeholders to advocate for inclusion of sexual health as an essential part of the healthcare within the universal health coverage. That is very, very important because the global agenda around health is looking at universal health coverage. And we must ensure that within the universal health coverage, sexual health is embedded. And we need to identify and support champions for this cause, be it the feminist movements, movements of young people, movements of lesbians, gays, transgender, intersex, all sorts of movements, so that we can achieve this. People with disabilities. Now, as we begin to interrogate this, we then realize that there are serious issues around that we need to focus. For sexual health to be realized for all, sexual rights must be protected. And we all know that this cannot be only to individuals, couples, families, communities, and countries. Not because these are not important, but because in most situations, we look at the binary. We don't look at, especially in Africa, where there's a whole lot of pushback on access to information and services, especially for young people and men who have sex with men and all the other groups that are. So we need to ensure that everyone is reached and everyone's right is upheld and respected. Therefore, we must affirm positive and respectful approach to sexuality and sexual relationships, pleasurable and safe sexual experiences for all, where there is no coercion, discrimination, and violence, which is based on human rights. So for us to be able to say that we are promoting sexual justice in public health setting, we need to have a very, very robust and inclusive service where we leave no one behind. We need to have a human rights-based approach where the rights and dignity of each and everyone is respected. We need to be able to respond to all the social determinants of health. You know, we know that poverty, culture, traditions, a lot of things have been predetermined, and these things end up ensuring that many people don't have access to services. We need to address inequities and the causes of inequities. All health services need to be stakeholder-centered so that a service, for instance, for people living with disabilities must recognize and factor in their disabilities, for instance, and know that they need to be able to be the ones who are the primary recipients. And they are not just beneficiaries, they are critical stakeholders. We need to ensure that there's access to comprehensive information and services across board. And I continue to argue that the discourse around comprehensive sexuality education, making it look as if it's only adolescents and young people who need comprehensive sexuality education, is begging the question. We all need comprehensive sexuality education that is age appropriate, that is inclusive across the lifespan. We also need to ensure that it is sustainable. You know, we don't want a situation people will benefit from access to information and services for just a short time. And therefore, we need to ensure that financing for comprehensive sexual health information and services in the public health system is important. We need to take advantage of technology. Technology can enable us to reach many people with information and even services at very low cost. And indeed, it can be the pathway to sustainability. Of course, it's not on the slide, but there is need for partnership. No one person, government cannot do it alone. Everybody needs to come on board, and this is it. It is a tall order, but it is doable, because after all, sexual pleasure is the right of everyone who chooses to find safe, respectful, and pleasurable sexual experiences, free from coercion, free from diseases, and that we don't have to continue to interrogate sexual health only from a problematic disease perspective. I hope I've been able to summarize and bring to you the presentation by Dr. Sarah Onyango, who I don't know if she's joined. Oh, she has joined us. I don't know, maybe she wants to say something in the next minute or so. Sarah, do you want to say something?
Thank you. Thank you very much, Uwem, for the presentation and for doing your best to try and read somebody else's presentation. I think it's very well covered. You've raised some of the key points that I wanted to bring out, really just highlighting how sexual health and rights are sometimes stigmatized and not adequately positioned within the healthcare system. And then in terms of the need for us to advocate to ensure that health services always include essential sexual health services. And I think also to really take advantage of some of the new knowledge and opportunities we have seen during these COVID times to better reach clients that are not necessarily facility-based, including digital and self-care as ways of reaching the client. And then most importantly, I think in all these cases, to recognize that services must be client-centered. But Uwem has ably covered the key points I wanted to bring out. And thank you for that. I'm on medication, and so I didn't want to take responsibility for this session. But thank you very much, everyone.
All right, thank you, Sarah. At this time, I will be watching a video. And this video is to add to tonight's discussion. We interviewed people on the ground who work in public health on a daily basis and who make use of sexual health services in public settings. Our first voice of the people is Sister Judy Ranapi. I encourage you to watch the video.
It's very, very difficult. A whole lot of healthcare providers are very demoralized. There's a whole lot of things that are happening within the healthcare system. But what I've seen had actually worked within our district is that we support each other. We form these WhatsApp groups where we connect with each other. Whenever we have challenges, we tell each other. When we have a shortage in one facility, we don't even bother to tell authorities. We actually just make sure that among the facilities, we make sure that we borrow from each other so that services can continue. But that is not enough. But through my experience, I've seen most people that work within the sexual and reproductive health arena are very compassionate. They love what they are doing. They're hardworking. So it's, despite all the other negative things that are happening around, despite the fact that they are not even getting an increase, They wake up every day and they go out there and they give the service, and they take care of the women and they refer the women appropriately. That's what I love about it. And that is why we found that having to form this close bond among each other and telling each other our differences and the challenges that we have, it's actually working. We've also found out that engaging with other provinces, they also have the same challenges that we have within the sexual and reproductive health arena. And we found that when we network with each other and support each other and share each other's challenges and also share each other's best practices, it actually works. We laugh about it. We moan about all the problems that we have. We laugh about it, but at the end of the day, we come together and we say, this is working, and we're going to have, for the moment, work with this while we work very hard to actually make this work. In the Western Cape, we're very, very fortunate because our MEC for health is a midwife. She supports sexual and reproductive health services. So now and then she has a word in, and everybody gets a fright, and you know, people want to find out how's the data going, what are we doing, what can we do to assist. So that is actually quite nice. And even when we have functions to actually say, a minister, we'd like to support the abortion providers, we know there's no money, but we want to spoil them for a day and give them a meal or so. She actually supported. And then when they leave the function, they go back and we get back to work and we provide a service that's much needed by the women and girls. So we are fortunate in that way. And we actually transfer whatever we think it's working to other provinces, and what's working in other provinces we also bring to us. I mean, we've just found out now that other provinces are using the churches to actually talk about sexual and reproductive health. And we were scared. We thought, you can't go to church and talk about these things, you know, and we're thinking that if we use what they're using, it'll actually work for our women.
Thank you, Yu. It's my pleasure now to introduce our next speaker to you. It is Dr. Kenneth de Camargo. He holds a doctorate in public health from the State University of Rio de Janeiro. He's currently a full professor at the State University, and he's also the associate editor of the American Journal of Public Health. You can read his full biography. It will be posted in the chat. It's my pleasure now to welcome him and to hand over to him for his presentation.
Thank you. First of all, I'd like to thank you for the invitation. It's a pleasure to be with you. It's unfortunate that we can't be really present with each other. I would love to be in South Africa, a country that I had, fortunately, the opportunity of visiting twice in the past. I'm going to share the screen to show you my presentation, and the title I chose is inspired in the movies, The Good, the Bad, and the Ugly. As was stated, I'm professor at the Instituto de Medicina Social, which is a postgraduate and research unit within the Rio de Janeiro State University. And these are my funders and the research group I'm part of. I think that before I can speak something about that, there are some peculiarities and some specificities of the situation here in Brazil that I think people should be aware of in general about our public health sector. The first thing is that healthcare reform was a spearhead of the movement for redemocratizing the country. During we had a military dictatorship from 1964 to 1985, and the pressures to have a better healthcare for the population was one of the driving movements behind the general movement for having democracy back. And even during this time, before it ended, the organized pressure from people working, from health workers and the feminist movement managed to create a comprehensive care program for mother and child, which is, I think, was a pioneer with regard to reproductive rights, although it had its problems, and in particular with regard to access to prenatal care and contraception. After the end of the military regime, we had a new constitution, and this is very important because which was promulgated in '88. And the logic, the idea that health is a right, is a citizen's right, and the duty of the state was enshrined in the Constitution. That provides a solid base for social movements to fight for the rights and fight for better care. So we created the National Healthcare System, which is known by the acronym SUS, was created, and healthcare is shared between several levels, federal, state, and city, municipality levels. And particularly primary care was adopted as a strategy to expand access to care in the whole country based on a model of family health programs. It is, and it's very important because it's based on families and it's territorially based. So we have teams which are, I'm going to talk about a bit more later, comprised of nurses, physicians, and community healthcare workers who have responsible for a number of families. They call it a module within that territory. And that includes in-house visits, not just the people can come to the clinics where they are based, but they also make in-house visits and work with the local institutions. One big problem, and I'll talk about that again in a moment, is that the system has been plagued by a lack of adequate funding since its inception. We have a two-tiered system. Actually, it's very complex because we have a public healthcare system and a private healthcare system, which sometimes exists in a sort of competition. And we have a private healthcare system, which is dependent on funds from the government, from the public sector. So this creates a lot of conflict of interest. The good thing is that the family health model is very comprehensive and inclusive. And all the principles that were outlined previously in terms of what sexual health should comprise are included as in the logic of the family health program. And the people who are working with the families in this program are supposed to be trained and have adequate training to work with this kind of situation. And that the services that are provided include access to contraception, to several methods of contraception, both involving drugs and even surgical methods. There is a provision for working, and that is done in several places, working with the local schools to provide sort of backup and professional help for the sexual education programs. And even gender assignment surgeries are available in the public health system. Although this is more or less limited to larger cities, particularly in the Southwest, the richest region of the country. We had a very important HIV/AIDS program that was considered an exemplary initiative that had the government working in tandem with academia and social movements. And this has provided a lot of input and a lot of work done around the respect for sexual diversity, sexual rights, and so on and so forth. The problems, however, is that we have a great heterogeneity in the country in almost everything that we look from in terms of cultural differences. I forgot to ask to please put the poll for people to have access to. We have a lot of differences in economic, social, cultural terms. And this reflects in the kind of distribution of services. As I said, the responsibilities are shared between the federal, the state, and the local levels. And this leads to huge differences you can have, even in the same city. I live in Rio de Janeiro, it's one of the largest cities in the country. And we can have side by side a very rich neighborhood and a very poor neighborhood. And the services are never the same, unfortunately. And not necessarily the people working with the family health program, particularly the physicians, were trained in the logic of the family health and community health services. So it's not, we do not always have the kind of preparedness and training that would be necessary to deal with those situations in the current practice. And we have a lot of interference from cultural and particularly religious issues in several areas. Abortion in Brazil is very restricted. It's only admissible in cases where it threatens the life of the mother or where it resulted from rape. A third clause was added for the situations where the fetus has some sort of problem that is incompatible with life, like anencephalia, children that have no brain. But even in these cases, the woman has a legal right to recourse to the public health system to have their abortion. Every other case is illegal, and this has created a lot of problems. And particularly with regard to rape, we had a number of cases, one of them very recent, where a girl, a very young girl, was raped by her stepfather. And in these cases, the abortion has to be approved by the judicial system. It was approved, but people from inside of the government denounced what was going to happen. And there was a huge demonstrations in front of the hospital where the child was going. It was really an awful situation. And things like that have happened repeatedly, unfortunately. And the really ugly part is that since 2016 here in the country, because of political reasons, there has all the advances that we had previously in terms of social issues, including those related to gender and sexuality, have been progressively eroded. We have a very strong conservative backlash. So, for instance, we used to have the equivalent to a minister-level secretariat for dealing with women's issues, which was very progressive and fostered. But many of these aspects are coded into law in Brazil. So we have very good laws protecting people from gender or sexual orientation discrimination. We have very good laws protecting women from domestic violence and so on and so forth. Their implementation, however, depends a lot on who's in power. And we had this secretariat, which was folded within a large section of government. And the person who was put in charge is very anti all those principles that were outlined by Dr. Esiet previously. And we have this whole argument about the so-called gender ideology, which has taken root and has been pressuring everything from schools to health services and universities to sort of having people falling into traditional gender roles. And funding, as I said, that was scarce from the beginning, became even more scarce after that. There was implemented a law that mandated a cap on government's expenditures. And this has created a lot of problems in all the public sector, in particular with regard to health, which is a large part of the public expenses in Brazil. And I'll try to present some data that I think would help to illustrate the issues we're facing. I didn't put on this slide, but recent estimate says that around 55% of all pregnancies in Brazil were not planned. So this shows that although we have, in theory, access to contraceptive methods and the information about those, things are not working quite as expected. And one major issue is connected to teenage pregnancies. There has been some progress, as we can see by this recent data. In recent years, it has been going down. From 2000, it was 81 per 1,000 adolescents and has fallen down. It's lacking the last number, the last digits to 2019 to 48 in 1,000. It's still relatively high. This is a complex problem because it's not just a matter of having better information, better sexual education, but I have some colleagues who have conducted extensive research with regard to pregnant and teenage pregnancies. And there are some social drivers that lead the girls to want to be pregnant as a sort of social ascension. The other issue is with regard to HIV and AIDS. We have had reasonable retrospect, but still have problems. In purple, we have the deaths, which are now 4.1 per 100,000, have been reduced over time. AIDS cases have also been reduced. One thing that I forgot to mention is that access to antiretrovirals is also provided through the public health system. And we have access to all methods of prevention, including PrEP and PEP, again, with differences between different places. But we still have a small but slightly raising the green bars for pregnant women that are HIV positive. We haven't had many, we have managed to control that, but problems in access to prenatal care have represented the limit. And finally, a very concerning indicator, one of the major concerns that we have, as was presented before, was stated before by Dr. Esiet, is with regard to sexually transmitted infections. And syphilis, as you can see, is totally out of control. The blue bars are for acquired syphilis, the orange bars are for pregnant women, and congenital is the red line. So it's relatively high. It is a Texas, but the main concern is that they are going up. So this shows that we are failing. Can we have the results of the poll up, please? Oh. So, okay, this is a very interesting distribution. Most people are involved with it, and I can see that we have the majority of psychologists, which is very important. That's an area that we haven't had. We had an expansion of mental health facilities here in Brazil, but they haven't been expanded as needed and are not always available with the family health programs. So finally, the last thing is that what kind of things that we have learned from this experience is that sexual health can and should be addressed by public health care systems, and particularly with this framework as having health as a right and sexual health as a part of this right. But this depends a lot on the existence of such programs and on the political will and popular support to have them implemented in practice and sustained in the long term. As I said, political changes have exerted a lot of influence in limiting the extent and the reach of the programs that we have. And one thing that I forgot to mention, but it's very important, is that one of the problems that we have with this approach is that quite often the whole issue of health is reduced to a very biomedical issue, and aspects of sexuality related to pleasure and to fighting discrimination and prejudice and so on and so forth are not necessarily properly addressed when we have a purely biomedical clinical approach, logic determining the response. So those are the ideas that I would like to share with you. I hope that we can talk more in the discussion. And once again, I would like to thank you for the invitation and thank for everyone who is watching this. Back to you.
Thank you so much, Dr. Camargo. I see there has been a couple of questions that has been posted and the question and answer, so we're going to save them for the Q&A at the end of all the presentations. So please stay with us until then and to listen to the answers. So next we have the video clip of another person on the ground that I had the privilege actually to interview. So please also go and watch the full interviews afterwards on our social media platforms. And this one was with Dr. Mabena. So we're going to watch a clip of that, and then afterwards, please go and watch the full interview.
We all know that at the moment, the health system is really battling under pressure because of this COVID pandemic. So I can't really say there's too much that is going extremely well in terms of service provision, but I must say the National Department of Health has taken great initiatives to provide online trainings on different services that are relating to the public sector, including SRHR trainings that are online. And they've introduced this since last year. So more people have been having access to these trainings without having to leave their work posts, but doing it online to try and make sure that people's skills and information and knowledge is still kept abreast. But as far as translating that training knowledge to services, it's still a bit difficult because a lot of resources are being diverted for this pandemic. So one of the good things that the department has also done in response to this is using private providers, organizations to link them with private providers to provide certain of their services that would usually be provided at a public setting clinic. Like for instance, there was a period of time where GPs were being provided with contraceptive commodities, so that the patients who would usually come for contraceptives at the public clinic and now are struggling because of the COVID pandemic would then be diverted to private providers to receive that care from those people instead without paying a fee. So that's one of the creative things that I think really worked well. It still needs a lot of tweaking, of course. and a lot of supporting the processes and the private providers better, but it is a good start.
Okay, so yeah, so that sounds definitely promising, you know, and even though we have these difficult situations, some good is coming out of it, unfortunately, or fortunately. So at this stage, other than the COVID, you know, issue that we have at the moment, what other aspects are there that you think we can still improve on?
So the access to contraceptive services, the access to abortion services, that has been really critical. I mean, there have been commentaries that have been written by different organizations to show that the contraceptive coverage within the COVID pandemic has really been severely impacted, as well as access to abortion services, especially within the public sector. I mean, we know that people can't always afford to pay private providers for abortion services, especially because it can get expensive. So that has really been a roadblock, a significant roadblock for women's health due to this pandemic. So those two are really key.
So to listen further, you can go and access the video clips on the platforms. We are now going to take a 5-minute break, and then we're going to continue to listen to the presentation of Professor Kheswa. So we'll see you in 5 minutes. You can quickly stretch the legs, get a drink, and we'll be back in a bit.
Who are we? We are not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learnt what so many of us have forgotten. The value of every single day. The preciousness of every breath, of every heartbeat. We make tears, tears of thanks for the release from pain. And then there's hope. The hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Alison, Seb, Topeka, and Zunaid. And that is why we are not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life.
Welcome back, everybody from break. I hope you have been able to grab something and just feel cool. It's nice to have you back, and it's my pleasure to welcome our next speaker, Jabulani Guilford Kheswa. He's a professor. He holds a PhD in psychology from Northwest University in South Africa and is currently an associate professor in the Department of Psychology at the University of Fort Hare in South Africa. You can read his full bio in the chat. Welcome, Jabu, my brother. Over to you, Jabu.
Thank you very much. I hope I'm audible to everybody who have taken their time to join us today. As you might have heard how others have presented, allow me to talk about a community that is often marginalized. Though I'm happy that Uwen and Kenneth have briefly, which are none other than whom we often interact with at the universities. So the title of my topic, or of my presentation, is Stigma and Discrimination Against Them in Accessing Sexual Health Treatment in Public Hospital. And the outline in the next slide is as follows. It will be the context. The next slide. In the next slide. It will be the context, of course, the human rights that I'm going to touch on, the discrimination faced by them in South Africa, the hindrances in South Africa, the cultural difference beliefs, the legal system, and the ethical framework. And finally, I will suggest the recommendation. In the next slide, I've just indicated that at the hospitals, even where there are clinics, you find most gay people, lesbian and bisexual, avoid seeking care because of the discrimination that they often face. However, in 1994, at the International Conference of Population Development, the United Nations reached a global consensus to promote the rights to sexual health treatment for gays. However, in the next slide, as I move on, you find most of our people are being marginalized, and their sexual rights are also demolished by health care workers. Yet, when you go to the definition by World Health Organization, it stipulates that sexual rights refer to the highest attainable standard of sexual health, sexual education, sexual relations, and the access to sexual and reproductive health care services, which could be free from violence and discrimination and violence. But for this community, you'll find that when they go to the clinics, you'll find that they are always being discriminated against. And as they are being discriminated against, you find that that in itself contributes to their predicament in such a way that their health got compromised, because research indicates, in the next slide, it indicates that as compared to the heterosexual people, they're subject to marginalization and social rejection from the same nurses and health practitioners who are supposed to protect them from being discriminated. Moving to America, UNAIDS found that there are gays and bisexual men who have contracted STIs, including HIV/AIDS, because they couldn't seek medical support for fear of being discriminated against. And this becomes a challenge. This becomes a challenge because once they're not aware of their status, they may continue to infect other people. And as a form of coping, in the next slide, you'll find that they will indulge, all right? And apart from indulging, they hide themselves now in seeking medical information on the internet. As in America, it was found that about 70% of LGBTI community access that. And so you can imagine in countries which are still underdeveloped, how do people who have been disenfranchised from the clinics access the internet? And in countries such as Tanzania, here in our continent, Africa, the sexually transmitted infections kept on increasing as HIV infection rate was found to be ranging from 11% to 30.2%. Hepatitis B ranging from 5% to 8%. And this is really a public health concern, because if countries do not take care of its own people, regardless of race and creed, there'll be much money that will be spent on helping those individuals. In the next slides. And in South Africa, what makes these people not to access or to go to the clinics? It is because some of the providers of health, they are religiously and culturally endowed. This is where you'll find a medical doctor passing a remark which is derogatory to somebody whose gender identity and expression is not as it should be, as assigned at birth. So they will tend to treat LGBTI community with contempt as compared to other heterosexual patients. And another hindrance among those that I picked up is the legal system. In the next slide, please. It has been found that not long ago, that in a study conducted by Mgomezeli and Duma in Tshwane, Pretoria, Gauteng province, of the 11 men who volunteered to participate in a post-rape care, they mentioned that when they had to lay charges against those who were raped, they were turned into a mockery. Because remember, South Africa is one of the countries where same-sex relationships, despite they've been legalized, but the prejudice against them is still lingering. And this reminds me of so many rapes that are taking place daily, even to lesbians, because they are women, of course. They will experience rape as well. And this reminds me of this harsh reality. There was a soccer player who represented our ladies soccer in South Africa, Yudi Simelane, where in 2008 has been brutally killed and stabbed. And it's the only case that I know of where the perpetrators have been imprisoned. But for quite a lot of many, and considering that in Guatemala Springs, where there are some homophobic attacks which happen often, I can imagine before or for those who survive, how are they being treated when they seek medical help? And there is PrEP, which it is not fully distributed in many clinics or public hospitals, which also a lack of it makes most people to be infected because they're being raped. So allow me to talk about what has to be done, especially in assisting people who are part of this community. There's a concept by Cornell in the next slide, which talks about revolutionary Ubuntu in the next slide. That emphasizes transformative counter-hegemonic struggle breaking out in South Africa, since most of the LGBTI individuals live in harsh circumstances, either be at the institution where they pursue their degrees or in their very same community. Like I have mentioned earlier, that yes, they've got human rights. However, wherever they may be, they're always being criticized, they are being prejudiced, and no one is there to talk on their behalf. The next slide. So, having shared this with you, the big question is, what is it that has to be done? So I should say this, as part of my recommendation at the same time, let us look at what the behavior change wheel is all about. It is quite systematic theory-based, which is underpinned by COM-B model, which has been found to be very effective in providing counseling for those who whose sexuality is consent, and even for alcohol. And the good thing about this behavior change wheel, it is useful in helping or identifying the barriers and to enable LGBTI community to access sexual health services. And it's also imperative that policies of inclusion are also being considered, that at the hospitals, there should be also some people who are most knowledgeable about the challenges faced by people who are gays, lesbians, intersex, and transgenders. In the next slide, there's also a framework of intersectionality and health equity, because most of the health workers, they are not fully equipped in terms of addressing the needs of this population. So we are seeking the government all over, because also even in developed countries, there is still that oppression of people who are in this population, and they are being shut off, so to say, at the clinics. So could you ever imagine if one person of your relatives or being your family member being marginalized? In the next slide. So in overcoming the challenges faced by LGBTI community, there should be advocacy for user-friendly services. Like I've mentioned, that there are nurses, should you go or encourage somebody who might have shared their sexual challenges to say, go to the wellness center and ask for PrEP. You'll be shocked to learn that in many parts of South Africa, especially accessible. It is only accessible in Cape Town and at the men's clinic, Yeovil Clinic in Johannesburg. And the bad thing about people who have been discriminated against, especially gay people and lesbians and the transgenders, is that they're not being given so much time as compared to the heterosexual patients. And you'll find that they're being ill-treated in such a way that even just before they leave the clinic, it is already known as to what was bothering them. That is why when in his first presentation, he talked about the ethics. We still run short of that among our healthcare workers, because our friends, our relatives, our students who have chosen or who live or who have declared their sexual preference, they are being exploited. And how I wish that we can collaborate as community members, as people who have influence in recreating the knowledge, that we could have a vision such as of Sisonke gender justice, in the next slide, where they talk about, or they emphasize that even the gender non-conforming individuals could enjoy equitable, caring, healthy, and happy relationships with whomever they would like to, without being oppressed in a democratic society. So it is quite imperative. So, as I close, my recommendation are none but conforming to the social justice that Kenneth and Uwen mentioned, that the Department of Education should empower educators as well, so that the curriculum could be extended, so that by the time educators and lecturers go out, at least people are enlightened. And also other provinces should also follow suit, because it was only Western Cape last year which has endorsed a policy on LGBTI. And it will be so wonderful when we accompany our friends, or they trust us so much with their illnesses that we do not label them when we help them or we accompany them to the clinics than to surrender. So I thank you for the time given. More than anything else, I thank the Heteronormative Net 10 project and Chantal Fowler, and to single out my mentor, Professor Nduna, who has entrusted me to come and present such a unique topic, as it built on what Uwen has touched on, and Kenneth. I thank you one and all.
Thank you, Jabu, for this very interesting presentation. Apologies for the technical hitches. And I want to encourage all of us to send our questions to the Q&A chat box. And now that you mentioned that Professor Mzikazi Nduna is your mentor, I want to say thank you, Mzikazi Nduna, for what you are doing for not just South Africa, but for the continent and indeed the world. We will now hear from our third and final voice from the ground, who is the patient, Uma, that kindly agreed to share some of her experiences accessing sexual health treatment in a public setting in South Africa.
I've had experience where it works, to be honest. It works. We just, in a way, walking into a hospital and be afraid of what you're gonna get. And we do not build that relationship with the doctors to say that this is my doctor, I can go deep and say whatever that I'm feeling. So it normally works. It's just that us, we have that boundary. And then again, you find that some of the doctors are not even welcoming. So you look at them, you can't actually explain what is happening to you. You don't want to go deeper because they're not welcoming. Sometimes they are so overwhelmed, they have a lot to do. It's not that they're not welcoming, but then we have that gut that says if you are on a help, you cannot. You cannot discuss some issues with the doctors. They're just not meant for doctors. So it's kind of difficult, but I think it works. coming to my personal experience, my doctor was a male doctor. So for me again to say to him, look, this is what I'm experiencing. I couldn't say it. And sometimes you find that some of the patients will tell you that I have spoken to the doctor and I got help, but it's not even assisting. And then they are afraid to go back and say, look, it's not helping at all. So you find that on our personal life, we suffer a lot in terms of that. And we normally now decide to speak among ourselves, you know, and what worked for another patient might not work for me. But just because we were sharing, you know, you would like to believe that maybe that will also work for what works for somebody else. And we're different, we go through the process differently. So it's important to talk about it, open up about it.
I now hand over to Corlia to please take the Q&A session.
Thank you. So we would like to invite our speakers to join us on the panel, Kenneth, and if Sarah is willing to also for a while maybe, and then Jabulani as well. And as you have said, also please remember to post your questions in the Q&A. We are going to see how many of them we can get in the time allocated. And just a reminder to our panelists to also please raise their hands when they specifically want to answer a question. So I'm going to start with a question that's actually addressed to Kenneth, if you don't mind. So with regards to the polarization as represented in the backlash to socially oriented programs, are there any novel approaches to recovering the split, and what are your recommendations?
Could you please repeat? I had a problem with the audio.
Sure.
The question.
So with regards to the polarization as represented in the backlash to socially oriented programs, are there any novel approaches to recovering the split, and what are your recommendations?
Oh, good question. I wish I had an answer. No, I don't. There's the problem. It's a huge political problem, and I think that it's the solution necessarily political. And there is a large articulation of many social movements, including feminist movements, LGBTQIA plus movements, and also from African Brazilian communities to sort of push back to regain terrain. I think that the huge divide, the problem is that there has been how can I put that in a way that I don't sound biased, but anyway, the issue with fundamentalist religion has become a problem, and they become a part of the coalition in power. And this has led to several problems. And with regard to particularly to LGBTQIA plus populations, Brazil, unfortunately, is reputed, I don't have the official statistics, but is reputed to be the country that has the highest rate of homicides against this population. We have made huge progresses in the past, but I think that only with a larger diffusion of the idea of a human rights-based approach to questions of health, in particular of sexual health, we'll have any lasting progress in this area. I wish I had a better answer for that, but it's something that I think every day myself, how we regain the terrain that we lost, unfortunately.
Thank you so much. Jim, do you want to take the next question?
Corlia, I give you the floor. You can.
Okay, thanks. Yeah. So I'm going to ask a next question. How does one get around knowledge vacuums that are left when healthcare workers who are trained in sexual health provision are reallocated to different clinics?
This for me or?
Anybody? You're welcome to answer.
I think that we have to, two things. We have to provide a better structuring of the curricula of the health professions in general, to have sexual health as an integral part of the formation of the professionals. And I think that continuous education has to be provided to people who are already in the field. make them more sensitive. And I think the experiences that we had in the past is having people from the affected communities working together with the healthcare workers. Because everyone, each person is the greatest authority in their own pain and their own problems. And having this kind of direct input from communities is I think is the most important. And I think, in fact, that's one of the advantages of the family health program when it does work, is that it's very intimately intertwined with the communities that it caters to.
And maybe related to this question, and maybe Jabu will be able to answer it from South African point of view, is the national health insurance the answer to the woes of sexual health provision in the public setting?
If I have understood it quite clearly, Michelle, we just cannot have a smooth sailing considering the atrocities of the past, where religion is being put as a solution, or actually as a whip, if you bring your sexuality to the healthcare providers. But educators, lecturers, as I have indicated, that they're the one who should play a role to mobilize, and also in their presentation when they teach about LGBTIQIA, they should present it in such a way that not gay people, nor lesbians are people without the future. The only thing that they know is to have multiple sexual partners. So it starts with the family, people in our community, you know. But if they are being brutally killed, because I remember at some point, even the late Robert Mugabe once said, is being gay or lesbian is being an African. So people are still holding to that ideology. So you'll find even lecturers, they're afraid of talking about sexuality, and it becomes worse if they bring LGBTQIA youth. So that is why we find others going to an extent of committing suicide, because the community in which they live is not friendly. Thank you very much.
Thank you. Kenneth, I'm going to go back to you. There was another question actually related to community workers, and they were asking, what is the clear categories of community workers? If you could elaborate on that.
They are actually people from the community that receive a special training and work side by side with the healthcare professionals. They work as a sort of in between or liaison between the community of reference and the healthcare workers, and they do a very, very important work in the sense that since they are part of the community, they know what's going on and the kind of problems they are faced with. And at the same time, they receive a sort of training so they can, they do, for instance, the most of the in-house visits are done by the community health workers. So they can detect if there are, for instance, domestic violence problems, they can report it. Cases where there is some sort of discrimination or access problems to the healthcare, they can intervene. They, in a sense, they are the backbone of the program. They are 5 or 6 times more than the healthcare professionals in the system, and they play a very important role.
Thank you. Job, I think this question you might be able to answer. How do we link mental health and sexual health in the public system?
That is for who?
Jabulani.
Okay.
Okay. The policy of inclusion should be encouraged. Secondly, our people should try actually to be transformative and respect people not for what they are, but for who they are. And so unfortunate that in most countries, even though United Nations tries, even World Health Organization tries to destabilize, the dominance of heteronormativity, but it's still lingering. We see most people being discriminated against by the same medical doctors who should be the providers and the protectors. So if there could be a policy which is being implemented and right down from the primary schools, because in South Africa at the moment, they talk about introduction of sexual education, and most Christian people or parents were totally against that. And in South Africa, though we are in our 27th year at the moment of democracy, but sexuality is still being politicized. And that has hindered even people to live double lives, because once friends learn that you are homosexual, or parents learn that their children are homosexuals or they're bisexual, they're being rejected. So a collaborative approach where the NGOs, which specifically address or comfort people who are non-heterosexual, they are being combined in policy making to level or to get rid of discrimination. I guess South Africa per se could go far, and the corrective rape could even be lessened. Thank you very much.
Thank you. Kenneth, I'm going to ask a question or pose a question to you, and that was specifically asked, what happens to the unwanted pregnancy when faced with an outcry against the abortion?
Well, in that specific case that I mentioned, they did manage to go on with the procedure, but it was awful because there were daily demonstrations in the front of the hospital. They had to hide the girl to bring her inside, and all the time that she was resting at the hospital wards, she could hear the cries of people calling her a murderer. We had another episode a few years before that, where a similar case where there was a local priest who excommunicated everyone involved. The parents, the girl, the physicians involved in the procedure, the nurses. The only person involved in the episode that was not excommunicated was the rapist. So you can see the kind of problem that we're faced with. The hard thing is that since the majority of the cases for abortion are illegal when people are trying to, this leads, and this is known in other countries, illegal abortion is very unsafe, it's related to deaths and infection and whatnot. And there have been certain attempts to circumvent that by, for instance, trying to create associations that for women who are still in the beginning of their pregnancies to have access to drugs that will facilitate abortion. But I just read a case that in a Brazilian state, as a woman was receiving from the post office the thing that she had ordered with the pills, she was apprehended by the police, which is a violation of confidentiality of the post office and so forth. So there is a huge repression against abortion, and even in the cases when it's legal. But and there was a huge backlash, for instance, when I think 5 years ago there was an attempt to regulate, because in the cases that they are allowed by the law, they can and should be performed by the public service. And the attempt by the then Minister of Health to make a sort of technical norms regulating this kind of thing was heavily censored and under attack. So I think we do need societal change and political change in order to advance in this region. But again, in this specific case, fortunately, that the girl was not forced to go ahead with that unwanted pregnancy.
Corlia?
Yes.
Corlia, I think there are 3 questions that we need to quickly get to. The first one is, how can educators help LGBTQIA+ youth access resources in both sexual health and education on sexuality? Who wants to take that?
I guess I did try to answer that.
Okay. Okay, Jabu?
Yes, I want to repeat what I said, that it is not easy, but it's so important that our educators, they become advocates for students or learners who are oppressed, and also to ensure that they abide by the law or the constitution. You know, in South Africa, there are schools whose values are Christian-based, and once found, we are even expelled. And just because they are autonomous in their operation, it becomes so difficult for parents or the community to win when children are experiencing that, you know, because even in countries such as Germany, there's somewhere where I read that any information that has more to do with LGBTI is being phased out, you know? And now the big question is, why so? So many things are written, they've been endorsed in their parliament, in their government, in their state, but there is still shortage or inadequate knowledge that address LGBTI. You can imagine when a teenager who is heterosexual, who feels free to ask quoted, but if an LGBTI learner is trying to share their encounters, they become a laughing stock. You know, so hence I'm saying we still need many policymakers who will also use other channels and other professionals to be called to the platform in sharing, you know, the predicament faced by LGBTI community. Thank you very much.
Okay, there is also, okay, I think the question for Sarah, maybe she has typed an answer.
Could I add just a small note to what Jabu said? This is another example of how this kind of conservative backlash influences policy. We had at one point a whole program that was dedicated to improve the conditions in schools called Schools Without Homophobia, which were created. There were a lot of instructional materials and how to train professors to deal with the situation and so on and so forth. And this was blocked in the end because the people from fundamentalist religions said that this was an attempt to turn children gay.
Yeah, yes, I think this is going to be an ongoing debate because the educators cannot give what they don't have. So who will educate the educators? And who will educate the healthcare providers to let them know that normality, the spectrum of normality, includes everybody.
I just want to go back to your previous questions on the abortion. Actually, one that links to that. knowing each country has its own legal procedures and it becomes difficult when they want to do something. And then there are some legal restrictions. So the person asks, what can you do then to help socially?
I think first and foremost, try to avoid unwanted pregnancies. I think that the prevention is always the best approach. And there has been a very long political struggle to enlarge access to abortion. And this is not only here, it's going on all over South and Latin America. Recently, both Uruguay and Argentina had approved very progressive laws. I hope that at some point this gets to here. But we have even worse cases in Central America. El Salvador and other countries have enacted such rigid laws with regard to contraception, to bearing abortion, that even women that have a miscarriage can be criminally prosecuted. It's insane. But again, I think this is a political issue that needs a political solution. And it's very hard for the healthcare sector alone to work with this.
Kenneth, I also want to ask you, in which ways can sexual health be medicated?
Okay, this is, I think, an important issue because since it's in the hands of healthcare professionals, particularly physicians, and I was originally a physician, we tend to think in terms of diseases and disease processes. So it's very easy to focus on disease prevention. Again, it's very important, but this not necessarily lead to the kind of comprehensive approach that we need with regards, for instance, to human rights or to fight against discrimination. I think the classical example that we have is with regard to one of the most effective approaches that we had with regard to HIV and AIDS prevention was the development of all these safe sex practices. And this involved fundamentally re-eroticizing the use of several barrier methods like condoms, for instance, as part of a sexual play. And this came out from NGOs, HIV AIDS NGOs. I think this is hardly something that someone from a medical background would come up with. So I think the problem is that we focus too much on a biomedical perspective. We can lose focus of many other things that are very important, like, for instance, issues of pleasure. Sexual education has to do with that also, and not just talk about how you prevent sexually transmitted infections, for instance.
I think we've touched on the next question as well. Is any other characteristics of the Brazilian family health approach that are related to providing an adequate approach to sexual health issues?
I beg your pardon, I lost the beginning.
Are there any other characteristics of the Brazilian family health approach that are related to providing an adequate approach to sexual health issues?
I think the idea, the fundamental principles that are behind it, I think they are highly conducive to this kind of approach. It's the idea of having comprehensive healthcare to look at the person as a whole and not just a agglomerate of biomedical systems, respect for rights, the need to think in terms of how people live their lives. I think all those are very compatible, and I'd say even go further than that, and they are indispensable for the correct approach. The problem that we have is that the people working with the family health program have not necessarily been trained with this kind of perspective in mind. We have specific medical residency programs, for instance, for family and community medicine. And I don't have the most recent numbers, but it's only a fraction of the total of physicians that are working with this program in Brazil that have been trained in one of those residency programs. But the whole logic of working with families, working with a territorial-based approach, I think is very important to sort of shy away to evade this kind of hegemonic biomedical perspective that would, in my opinion, tend to put aside any other considerations that are not directly disease linked.
Okay, thank you very much. Jabulani, I think this might be a question for you. What are some of the strategies for drawing the marginalized into the public health system? after they have had bad experiences in the system?
All right, thank you, Corlia. I'm happy that Kenneth has touched on resilience effect that has to be from individuals or individual families. It is still a challenge, I suppose, for such a population, especially after they've been discriminated against. But the struggle shouldn't be to be left hanging. We've got Net 10 at the universities, which try to address the marginalization and the existence of gay people. And I should say, of the Net 10 universities that have become part of trying to destabilize heteronormativity, I should say universities such as Rochel in South Africa, West University, and West, among others. They have established some organization for young people where they come together, and through sport, they make sure that they extend their existence. And luckily, in those institutions, they also have subject or courses in which they infuse LGBTI challenges when they talk about topics such as GBV and sexual education. Thank you very much.
Thanks so much.
Corlia, just one thing that I would like to add, because to avoid misinterpretation, is that when I talk about families, I'm not talking about heteronormative traditional families. The program acknowledges that families can be any kind of same-sex marriages, multi-generational families that live in the same space. The majority of the people there are the families that are under the purview of the family health programs, for instance, are led by single women with multiple children. So just to make it clear, another important thing is not to have this kind of heteronormative approach in the head all the time. And this is another thing that is usually taken care in the training of these professionals.
I want to link up with this. There's a practical question actually that links up to this. Are there any initiatives to educate the families to accept and support their sons and daughters who are gay, lesbian, bisexual, and trans?
I'm not aware of official government programs. There is a lot of work done by NGOs working with healthcare organizations. As I said, there was a program for schools that I think was unfortunately interrupted. And in the general norms that should preside or should organize the healthcare in the family health program, this kind of thing is included, that people should respect sexual diversity, that people have a right to be whatever they want to be. But as I said, unfortunately, what is written in the norms is not necessarily implemented in the ground. And I think that in this particular issue, this is something that people working with NGOs, both LGBTQIA plus NGOs and HIV/AIDS organizations have done a great service in terms of trying to destigmatize, reduce prejudice, and I think a lot of progress was done, but this is an ongoing battle.
I'm going to end up with a question that was actually posed to Sarah. So I think, if you can also maybe try to answer this. You spoke of self-care being a potential tool for patients as an alternative with the example of STI screening. Do you think there's space of using telemedicine in the provision of abortion care as a self-care intervention, particularly medical abortion and early pregnancy recognition?
I think this has had to be implemented in the last year because of the pandemic. That has upended everything, but also has led to a lot of problems. There has been a spike in domestic violence, for instance. People are confined in their houses, and lots of problems have arose from that. I think that as an additional measure, I think it's important. I think the risk is pushing the responsibility for taking care of the shoulders of people that need it. I think that it's important to be encouraged. It's important that people can be, to some extent, take the reins of things. But also, I think it's important to have the backing of the healthcare system to provide for the needs. I think it can be very cruel if you leave everything in their hands. And in the case of abortion, as I said, with all that it involves here, that has been the case. I'm aware of self-organization of people trying to get access to medication, but it's in theory against the law, and that creates a host of problems.
Yeah, well, Sarah, do you want to maybe add to the answer to this question?
You want Sarah to add, or you want me to add?
You can add, please.
I'm happy to just make a brief comment. I think the question has really been addressed and answered well. You know, with self-care, we have an opportunity to empower clients to take greater control of their health, including you know, abortion needs. And as Dr. Kenneth has mentioned, you know, we have seen a lot of this happening during the COVID outbreak when clients were unable to get these services from the static health facilities. So it's an opportunity we have. You know, women are doing these. Women have continued to manage their sexuality by providing these services to them. It's not denying them access to the health provider. So we must still, as he's mentioned, continue to provide an opportunity for referral if they need further management, but also an opportunity to consult or to get counseling and support as and when needed. But it's a great opening for us. You know, we can get these services to clients either through local pharmacies or you know, community health workers. And it just improves the access to those who are not able to get these services through static facilities. Thank you.
Thank you so much, Sarah. Thank you, everyone. Unfortunately, we are running out of time. So, Uwem, any closing comments from you?
My take is this. We are at a critical moment in the history of humanity. One, we must respect the sexual agency of every human being. Two, we must work towards providing access to age-appropriate comprehensive sexuality education for all. Three, we must work assiduously to ensure that access to quality sexual health services that is affordable and sustainable is within the reach of each and every one, so that we can guarantee the right to the sexual rights of all, including the right to sexual pleasure. Thank you.
Thank you so much, Uwem. Yes, I also agree with him. And you know what stood out for me from all the presentations are the similarity in the type of problems that we have. And also based on that, I think we can really learn from each other in approaches to solve some of these problems. And, you know, unfortunately, I also had a couple of questions that I would like to go on asking everybody. But thank you so much for answering the questions. It's sometimes a bit difficult being on the spot, but I think, you know, we really answered most of the questions that were posted. If we did not get to your question, we apologize for that. And some of the contact details of the speakers are available should you want to pose any further questions to them. So on that, I'm going to hand back to Anthony just to end off with some closing remarks. and to just make some comments on what is also lying ahead this year. Thank you, Anthony.
Corlia, thank you so very much. And thank you for your words and wisdom. And to all the speakers and moderators who gracefully navigated the challenges that technology threw at us this evening, for sharing your experiences and your views on this vitally important subject. I think a big thank you and congratulations must go to Avri Spilka and her team, who really worked incredibly hard to put a lot of different moving parts together to be able to bring you a really complex, interesting, and provocative webinar this evening. So well done to all of you. Thank you to CIPLA for your support. And just to remind you once again to sign up in your memberships for WAS and for Sasha. Once again, a reminder to register for the Congress coming up and to invite you to join us next month for our next sexual medicine webinar. It's going to be on sexual medicine, and it's provocatively entitled Breaking Boundaries in Sexual Medicine, a Peek Beyond the Clinic. Something somewhat different, a little tantalizing temptation for you for a month from now. So look out, and we look forward to joining you once again next month. Good night.